We can go ahead and get things started. So my name is Nicholas Franco. I'm a coordinator for the ACP Long COVID Interest Group, and it's my pleasure to welcome Dr. Lindsey Knowles and Dr. Tracy Herring today. And I will pass it over to Dr. Chopra to have a full introduction.
Thank you, Nick. Hello, I'm Anita Chopra. I am an internist and one of the lead physicians at the Long COVID Clinic at the University of Washington. And today I'm so excited to welcome two of my colleagues, fellow researchers, Lindsey Knowles, Dr. Lindsey Knowles and Dr. Tracy Herring. Both are assistant professors in the Department of Rehabilitation Medicine at the University of Washington, and they are lead providers at our Long COVID Clinic. Welcome, Lindsey and Tracy. So today we are going to focus on the psychological aspects, mood disorders and changes in long COVID and other infection-associated chronic conditions. And I hope that Lindsey and Tracy, you can shed some light on how you manage these patients. Now, one of the very interesting things that I do want to share with our audience today is that uh, Lindsey and Tracy are part of the group psych rehab program. This is one of the most successful programs at our long COVID clinic, which is a rehabilitation program for long COVID patients. This is a much requested program, and there are long wait lines often for our patients, but they report a benefit. They report improvement after having gone through this program, and many of our patients, they request to do this training again. So that's a testament to Lindsey and Tracy and their work with our clinic. So Lindsey, I'll start off with you. You work closely with patients navigating the psychological toll of long COVID. What are the most common emotional or cognitive challenges you are seeing in your clinical practice?
Sure, thank you. So I think generally what we know is that, 1 in 5 long COVID patients is presenting with depression, anxiety, post-traumatic stress disorder, and or a sleep disturbance as an issue. So that's a fairly high prevalence in our patients already. And then in my own clinical practice, I see depression, often anxiety, sleep disturbance. And when I say sleep disturbance, this might be insomnia. Patients are frequently diagnosed with obstructive sleep apnea as well. And then we work on things like making the CPAP or BiPAP machine more usable for them as well. Brain fog is kind of a general concern of many patients. And this is usually issues with kind of working memory, executive functioning, attention, for example. And stress. So a lot of stress, really focused on losses, changes in social roles and responsibilities, loss of employment, financial difficulties because of these issues. So a lot of stress and stress management too. And then fear of reinfection is another thing I frequently see, especially with my individual patients. And so just this idea of how do I reintegrate into the world? I'm continuing to mask, the rest of the world isn't. I'm not sure who's vaccinated and who's continuing to get boosters. And so that will often look like treatment for anxiety around kind of that reintegration and really trying to balance risk of reinfection and engaging in things that give our lives meaning and joy. So I would say those are the biggest things.
Thanks. And I will know we'll be Dr. Chopra and I will be directing questions to each of you individually, but of course we'll take input whenever you feel like you have something else to say. So this question is directed at Tracy. So you lead group-based rehab for long COVID. Could you talk a little bit about what those sessions look like and kind of how peer dynamics influence recovery and resilience for patients in those group settings?
Yes, certainly. It's a great question. And this is something that we are conducting research on, actually. So we conducted qualitative interviews with some of our participants in these groups. And one, I think, really notable takeaway was that we conducted 20 interviews, and 19 of those interviews involved people mentioning that the group dynamic and having a shared experience and the group cohesion was one of the most important aspects of the group. And so to your point about dynamics being important. And I think, another takeaway we learned from the qualitative interviews was that participants or patients really found a lot of value in being able to help other group members. So not only did they feel supported, but the opportunity to show up and support other group members was particularly important. The other, I think, piece here in terms of the dynamic that we noticed is, that patients might be more likely to try or use one of the strategies we're teaching after they hear from one of their fellow group members that it was effective. So, we, for example, will talk about deep breathing and diaphragmatic breathing as helpful for the symptom of breathlessness, or helpful for anxiety and stress. And we go through the science and we practice it together. And people will be like, sounds good, sounds good. And it's sometimes not until a different one of their group members is like, guess what, guys? I tried the breathing and it was really helpful. And then we see kind of, and I mean, this is not always the case, but then we kind of can start to see other group members showing increased interest and willingness to try. So again, I think these are all reasons as to why delivering this intervention in a group we're finding has added value. Not that individual doesn't, but there are unique elements of the group that I think are particularly important for this patient population.
Thank you, Tracy. And I'm going to go off script a little bit, and there's a question in the chat that I will, ask you. But before I do that, can you please talk, and both of you please feel free to add in, what is the referral process to you guys? How do people refer patients to you? How do the patients end up coming to see you in clinic?
Go for it, Lindsey.
Okay. So generally our patients are referred to us through one of the physicians in our long COVID clinic. So you would, and I know unfortunately we have a wait right now to be seen in our long COVID clinic, but our patients would be seen by one of our long COVID providers. And then that provider would place a referral for rehabilitation psychology. And that would usually start with kind of this group, this self-management group where we're focused on biopsychosocial strategies to help manage the most common symptoms of long COVID. And we also see patients individually as well. And that's that kind of individual or tailored one-on-one work for about 12 to 14 sessions.
So the question in the chat is about someone who is a vet connected to Spokane VA Medical Center. Are vets allowed to get on the wait list?
Dr. Chopra, I think so. And Tracy, please feel free to jump in. I mean, I think as long as you become a patient of our long COVID clinic, then you can absolutely access rehabilitation psychology services through our program.
Thank you for that clarification. And Nick has a follow-up question. Nick, please go ahead.
I did have one last question, or one quick question on that. I think we're starting to see group medical visits in a number of different specialties, and I think folks are seeing their benefit. Part of our research is on doing similar type interventions for loneliness, and I'm wondering if if your sessions are on Zoom, in person, or kind of offer a hybrid model. It's just logistically interesting, and I think it looks at some interesting points as to what certain populations can and can't do.
Great question. I'll start, but please, Lindsey, jump in. We offer our sessions over Zoom. And again, as I mentioned, that study that we are currently finalizing our data analysis, that was a common theme where people were grateful that the intervention was delivered over telemedicine for a couple of reasons. One, it made it easier to access. And then to Lindsey's point about fear of reinfection, that was eliminated, right, because we were conducting this virtually. So there was overwhelming support for the Zoom platform as the delivery mechanism, if you will.
Yeah. And maybe just zooming out on that for a moment too, we can, Dr. Chopra, we can put the citation for a protocol paper that we wrote that describes the group as well as our study of the group. And then we'll be publishing those outcomes soon, hopefully, but of course can kind of share that citation. And then just to zoom out on like, what is this group, right? And so I've kind of mentioned, and Tracy mentioned, it's, self-management for long COVID symptoms. What we do is we meet by Zoom weekly for 6 sessions. And then we have 2 booster sessions about 2 weeks after the last session and then 4 weeks after the last session so that we can kind of check in and see how things are continuing to go. And the group, as I mentioned, really takes this biopsychosocial perspective, knowing that our patients are doing a lot to try and medically manage their symptoms and their condition. And that really matters. That's not exactly something that we can help with, but we are one part of multidisciplinary care. And so while they might be taking care of some of the more biological aspects of their condition, with medications like low dose naltrexone for fatigue, for example, we're going to be focused on other things that also impact biology as well as psychosocial factors. So that includes the diaphragmatic breathing that Tracy was talking about, that we know kind of acts on the nervous system to really engage that parasympathetic nervous system response to reduce stress, improve sleep, reduce shortness of breaths, like so important. And then we also focus on things like pacing and reprioritizing for fatigue. For sleep disturbance, focusing on sleep hygiene. Easier said than done to make changes to our sleep that can really help us optimize our sleep drive and our circadian rhythms. We talk a little bit about how to improve attention for cognitive functioning. And we really spend a lot of time too on how do we cope with the anxiety over the uncertainty of living with long COVID, this novel chronic health condition where research is ongoing into medical treatments for it. And then last, we talk about communication. How do we communicate effectively with our healthcare providers? And also when communication difficulties come up with our loved ones who are now maybe trying to figure out these changes in social roles and responsibilities, how do we do that in a way that honors our limits based on our symptoms, but then also allows us to team up with those we love to still, again, show up in our lives and engage in a way where we can kind of lead meaningful and joyful lives. So that's just kind of a zoom out on what we try and do with the group.
That's an excellent overview, and I think that this is a very holistic framework, and it goes in tandem with, the sort of pharmaceutical management or physical therapy or other rehab strategies that we are using for these patients. And this has been a very, very successful program. Lindsey, many long COVID patients, they report being dismissed, feeling dismissed, misunderstood. How do you approach the psychological impact of this medical invalidation and diagnostic uncertainty? How do you deal with that?
Yes, a great question. I try and take a trauma-informed approach, and what that really simply means is trying to read up on, get more knowledgeable about the ways in which our patients experience trauma as they are being treated for long COVID or moving through the healthcare system. So various kind of ways that they can be affected. And then really validating. So recognizing that, being able to name that with patients, kind of validating their experience of kind of trauma where it comes to kind of having symptoms being dismissed or this long time to diagnosis, or for example, the trauma of a hospitalization or a job loss and those kinds of issues. And then part of that approach also involves then building a relationship where there's a lot of transparency and trust. And I have to earn that. And part of that is making sure that I am transparent and then hopefully building a relationship where the patient feels safe to disclose these experiences, whether they come up in their work with me and I misstep and I get to learn from that or from their other experiences as well. And then again, part of the trauma-informed care is also really trying to act in line with the principles of multidisciplinary care. And so knowing that, as now a central care provider for this patient, how can I help connect them to the resources that they need? So luckily, as you know, we're in a clinic where we have access to kind of different specialties, whether it's physical therapy or social work or vocational rehab. What that might look like is if I'm working with a patient who's experienced job loss, or they're thinking about how to get back to work, maybe a referral to vocational rehab to help them think through how they're going to advocate for themselves as they ramp up their FTE over time. So that's the approach I take. And then just maybe a tidbit is, sometimes we've had participants show up in the group that we just talked about being really skeptical about why are rehab psychologists running a group for long COVID patients. And I think just making time and space to hear that and then explain more about what the group is about, and that it's not for everyone, but we're here to help really with some of those more kind of psychosocial factors that they might be facing. I think that transparency ends up being really helpful. But we have had people show up in group and think like, is this group a form of gaslighting? And it really isn't, but we have to explain like how and why it isn't, that we're just a part of care.
Great, thank you. So this is a question for Tracy. So cognitive dysfunction or brain fog, I think, can really affect people's identity, especially those who are very high functioning prior to getting sick. How do you help patients psychologically reframe or adapt to kind of the loss of their functioning in this very important way?
Yes, I really appreciate this question, and that you highlighted the distress, and we do see this clinically quite a bit. So I think always the first step is normalizing that this would be distressing, especially if your high functioning is part of your identity and has gotten you places in life, and now there's been a shift. Of course, that would be distressing. So just starting with the normalization. And then I also like to always give some psychoeducation that for people who identify as high functioning, whenever there's any slight change on testing or just perceived change even, that will be distressing because it's so noticeable. And sometimes it's not even picked up on testing. So that can be a bit confusing or invalidating. And so in our role, we definitely highlight or normalize that this would be, of course, distressing. And then I think, from there, I take a few approaches. I think my first question, of course, is like, is there anything, before we jump to the coping and the adapting, are there any other skills we can do to optimize functioning around cognition? And so is that perhaps a referral to speech therapy to learn cognitive compensatory strategies sometimes? And again, I do this carefully because I don't want people to think I'm invalidating their symptoms. But we find that sometimes because it's so distressing, it increases anxiety. And when distress and anxiety are increased, our cognitive function is inevitably worse. And so what can happen is people will then start to only look for evidence that supports that they're not doing well cognitively. So when they walk into a room and they forgot why, they'll think, oh, here's another example. Or they could constantly be looking to confirm that something is terribly wrong, and then that makes the anxiety worse and the distress worse, which then continues to make cognition worse. So sometimes just checking to see, like, is that at play? And if so, we have strategies to help people reduce their distress and anxiety, which sometimes ultimately helps them increase or improve their cognition. An example that comes to mind, I had a patient who she acknowledged, she said, I'm so anxious about my brain fog and that I'm slipping cognitively that I know my anxiety is getting in the way. So she was on board with this. And so I felt comfortable assigning her this homework of spending the next week looking for or celebrating or acknowledging every time her cognition, she was successful in terms of her memory and her attention, and then also looking for every time that other people had slip-ups, forgot why they walked into the room. And the funny part of this, and it was totally accidental, is I'm scheduling her follow-up appointment, and we said, okay, let's do this date and this time, and then we started talking about something else, and then I pulled up the schedule to schedule her, and I said, wait a second, what time did we say? And I didn't even mean to like test her, but she said, oh, you see, you forgot right there. And I was like, exactly, like that's what I want you to do for the next week, is look at how people in your environment are also forgetting. And you have to be careful here, because you don't want to invalidate their challenges at all. That's not what the homework assignment was. It was just to help them see that perhaps they are doing better than they think they are, to reduce the distress and the anxiety, which then ultimately gives them a chance to get rid of that interference that could be exacerbating cognitive problems.
Tracy, this is so, this rings so true, what you just said about patients. And I've had so many sort of conversations with patients where their whole lives have been turned upside down, because they are used to the patients we see in the clinic. Most of them are have been highly sort of functioning intellectuals
Yeah.
who are now having problems even with sequential thinking, processing, word recall, and their ability to think, okay, what comes next, what step is next, or just comprehend that step is difficult for them. So I think that validating their symptoms is so very important, and that's the first step, to tell them you are not alone. And I think this is what these groups will accomplish. This is the number one thing that they accomplish, for them to see that they are not alone. There are other people like them, which is the, I think, the builds up their confidence. Lindsey, can you describe a moment in these group sessions where something happened unexpectedly? It was powerful, or a shift, or an insight, or a breakthrough that you saw uh, that was unexpected.
Yeah, you just made me think of one that I'd love to share, and I have another if we have time. But frequently in the first session, there will be a lot of tears shed, because this is the first time many patients are meeting someone else with long COVID. And so a lot of folks, we invite people to introduce themselves briefly, to share about their long COVID journey, but also to share what they're hoping to get out of the group, and one thing outside of long COVID about themselves, because really trying to think of ourselves as whole people. And after we do these check-ins and we kind of introduce the idea of the group and what we'll be doing, a lot of people end up getting very emotional just hearing from others, feeling validated, as you were just saying, about what their experience is. Others are experiencing that. And then also feeling like they're getting a lot of hope too from hearing the ways that other people have had some improvement in certain symptoms, or they've worked around or managed symptoms in certain. And so I think it's really sometimes the group diversity that's a strength, and then having that long COVID experience to anchor it, just from that first session, and then it builds from there. So the validation is so important. And I think just the other thing that will be quick is, in one group we had a mother who had been working and had to leave her job because of her long COVID symptoms and her level of disability, that she'd experienced a big change in social roles and responsibilities as part of that, including kind of like her functioning as a mom. And when we taught diaphragmatic breathing, she thought, this is something that I could bring to my family and my kids, because I know my kids struggle with stress and anxiety like most of us do. And so she then started practicing this really simple breathing exercise we do with her family. And she came back a few sessions later and told us about that, that it now is a practice that they've come together around to practice every day together. And it's a way that she can support her own care and support her kids in a way that she hadn't felt like she hadn't been able to show up the way she wanted to, for a while. And that was very moving to our group in terms of seeing how that was kind of changing some of her relationships. And so we had another group member who decided to practice it then, as Tracy said, hearing that it worked for someone else, experimented with it for himself, and it completely resolved his shortness of breath. Because over time, from practicing it, he just began to integrate diaphragmatic breathing into his normal breathing style. And that helped him, on that biological side as well. So I think that was really special for our whole group to see kind of the breakthroughs and how this skill could be used for, lots of different symptoms or family social issues as well.
That's awesome. And yeah, I think So this is maybe a question for both of you, but especially given the impact that these kind of group sessions have had on patients, are there any specific approaches or modalities or maybe things to avoid that clinicians could potentially adopt into their practice? I know a group setting is different than maybe a normal kind of like one-on-one office visit, but I think we can extrapolate here kind of broadly.
Ooh, I love it. Looks nice. You're all green. Hey, I love the color.
Tracy, do you want to start?
Yeah, Nick, are you thinking in terms of like a individual session or a group session? Like kind of these for these takeaways?
You know, I really think it could be both. I think if there's something that you think would be appropriate for from individual sessions or the group sessions that clinicians could take to their kind of practice. Because the reason I frame it that way is I don't think it's usually practical for most clinicians to say, hey, next month we're going to adopt a 6-session group therapy session or you know, group office visit. So kind of what little things can we take from that maybe to a kind of more traditional clinical setting?
Yeah. Great question, Lindsey. I look forward to hearing your response after mine. First thought is I think to reiterate what's already been said, which is ensuring that we validate and normalize patients' experiences. And I think part of that involves normalizing that at least the mental health component, right? So I think unfortunately, because of the history of how many patients were told, you know, these symptoms are in your head, they're all psychological, the gaslighting, the dismissal, I sometimes worry that we'll swing too far the other way where we won't talk about mental health at all. And so continuing to integrate this discussion or assessment around mental health is just so important because of the mind-body connection, of course. And so one thing that I think can be helpful if you're a clinician is to remind patients that we would expect there to be some symptoms of depression or anxiety because this is distressing. It's changed your function. It's changed your social roles. And so again, really normalizing the role of anxiety and depression in the context of chronic illness and inviting that topic into your assessment and your discussion is one thing that we really highlight in the group. And I would love for that to be in more medical settings.
I agree, Tracy. That's obviously second what you said. And I'm not sure that this is going to be appropriate for all providers and clinicians given the limited time and appointments. But, if a patient is open to it, and they are interested in kind of the physiology of the nervous system, which we know can be impacted by long COVID, and they want to adopt like a really easy practice that we know kind of stimulates that vagus nerve and really helps reset our nervous system and push us into that parasympathetic resting and digesting mode, you can introduce diaphragmatic breathing and do 10 breaths with your patient. There are other breath exercises, of course, as well. But again, as Tracy said, if a patient feels validated and this isn't going to feel like dismissing what they're experiencing and they're open to it, I think a small or a brief skill like that can reap many benefits if someone's open to that at this point in your treatment.
Lindsey, this is so powerful what you said about stimulating the parasympathetic nervous system. This not only will help with their mood, it can also help with other mast cell stimulation type symptoms that they might be experiencing, and it will help with their lung function as well. It's a sort of a pulmonary rehab. But there's actually a question from one of the attendees on this. Can you talk a little bit about diaphragmatic breathing? And if possible, can you explain the technique so that providers may be able to share it with their patients?
Yeah, I would be happy to. Tracy, I also, if you would like to do it, you're welcome to. Right.
Go for it. You've been on a
Okay.
roll with this topic.
I do love diaphragmatic breathing, clearly. But yeah, I think, and I can share a resource as well on this. There are lots of guided recordings. And as I mentioned, it can be really nice and brief. And so what we try and do in the group is explain that physiology first so that we can get patients buy-in. Like, we're not just trying to kind of breathe our way out of what you're going through. Really, we are trying to impact the central nervous system and activate the parasympathetic nervous system. So a little bit of explaining that fight or flight sympathetic nervous system response that I think a lot of people can relate to, and then explaining what it's like when we're in that parasympathetic response setting where it's more rest and digest. That can help in terms of patient education. And then saying that when we do diaphragmatic breathing, just the actual motion of it, we know kind of triggers or presses on that vagus nerve, and that the vagus nerve, that stimulation moves us into more of that parasympathetic response. And so one way we can do that is with the diaphragmatic breathing. And so everyone, if you want to, please feel free to just go for this. I'm going to describe it exactly how we do in the group, which is I would just welcome you to put one hand on your chest and one hand on your abdomen. And just to take a few normal breaths. That's how you normally breathe. And to notice to yourself, which hand is moving more? And so just kind of silently taking note of if the hand on your chest is moving more or if it's the hand on your abdomen. Your abdomen is where your diaphragm is, just as a little reminder there. And so what a lot of people notice is that the hand on their chest is moving more than the hand on their abdomen. And so what we're going to do now is really simply, we're going to take a few breaths where we are trying to get the hand on our abdomen to move just as much, if not more, than the hand on our chest. And you don't really need to provide more instruction than that. Really, it's a feeling thing. And our hands are really basic biofeedback tools. So I offer to patients that you can go ahead and breathe through your nose if that's comfortable to you, you're not congested. There's some benefits to nasal breathing. And so if you can breathe through your nose and try and breathe in a way that you can feel the hand on your abdomen rise with each inhale and fall with each exhale. And if you can breathe in and out through your nose, great. If not, you can exhale through your mouth. And we want to take about 10 breaths like this. They don't have to be particularly deep breaths or slow or long. We are just focusing on the hand on our abdomen and making sure it's rising with each inhale and falling with each exhale. So take about 2 to 3 more breaths. And if you notice you start to feel lightheaded, just return to your normal style of breathing. Good. And when you're ready, you can drop your hands. And in group, we would definitely ask, what did you notice? Without saying, did it feel good, right? Instead, it's just this open curiosity. Maybe it made things worse, and that's something to explore. Or maybe for a lot of people, they'll notice, I feel calmer, or I just feel more relaxed, right? And then they get a sense of, oh, I really did activate this parasympathetic response. And it's there whenever I want to take kind of 10 breaths in this way. Sometimes it can get complicated by pulmonary symptoms that folks have. And so that's why we offer, if you feel a little bit lightheaded, come back to your normal breathing. And the more you practice this, the more stamina, really, because it is pulmonary rehab, like you said, Dr. Chopra, the more stamina you'll develop. Just keeping it simple, not trying to breathe super deep. It's really just about the movement of the diaphragm.
This is so very important because this is not just mindful breathing. Explaining to them physiologically that they are activating the vagal nerve and they are activating the vagus, the parasympathetic system. Uh, that in long COVID patients is a very significant thing. I mean, that's something that has, many more consequences than only on their mood. That also impacts their entire gut-brain axis as well. So, Lindsey, as a follow-up question to this, what does recovery mean to you in terms of long COVID patients? Does it mean that they are returning to their pre-COVID functionality? And how or does it mean that they are adjusting to a new normal? And how does your program help patients redefine or reclaim that hope, even when they are still facing these chronic, clusters of symptoms?
That's a very important question. I think you said a lot of it there too, Dr. Chopra. So I would say how I would define recovery, what I hope for all of my patients is that they will get back to their pre-COVID functioning. That is what I hope for, that there will be treatments for long COVID that reduce symptoms, that potentially lead people into remission from long COVID and from their symptoms. Given where we are right now, it's so novel, right? And research is ongoing. And so just acknowledging that since we don't have any, certainly don't have a cure yet, and I think that might be especially difficult to find given the multi-system involvement here, but there's good research being done from different sides to kind of target these different symptoms and systems and the symptoms related. So while that's ongoing, exactly what you said about adjusting to the new normal. A lot of my patients say that to me, like my new normal. And I think sometimes they come to the group or individual sessions feeling really resigned about the new normal. And so it is about defining that for them. First of all, holding the pain and acknowledging how difficult and disabling their symptoms can be. So always holding that as true. And at the same time, what does give your life meaning and joy? And so this is where we might look at their priorities and maybe reprioritize based on honoring their new energy limitations, for example. Where are we going to really place their energy and their time, since they have to allocate it differently now? So that new normal hopefully will be based on their priorities and honoring what their limitations are. And for some patients, that also might mean challenging themselves in certain ways and seeing symptoms improve as well. We see that too. So symptom severity can improve, which is wonderful. And then also the way patients manage their symptoms can improve. So you may have chronic fatigue, but if you implement or practice pacing in a way that helps you rest, which is key, and then be active in a way that's kind of for a safe amount of time before you rest again, it's incredible the amount of important things that you can get done in the time where before it felt like you were kind of just in a crash, if we kind of get stuck in that boom bust cycle. So that's a long answer, but I think we kind of go over all of those topics when it comes to the new normal, because I think the new normal can be a very depressing idea. And so we do help them redefine it and keep the hope of research is ongoing. There are many folks who are really devoted to understanding medical treatments for long COVID. And until that time, we're going to try and support you to live your best life in this new normal and define what that is.
Thank you, Lindsey. Before Nick asks the next question, I just wanted to make two comments. And the first is that, there's when we are talking to patients, we see patients in the clinic, we tell them that there is no one sort of good treatment for long COVID. There is not one medication developed yet, but there are different strategies that come together. Really a 360-degree holistic approach to managing these patients, which includes, lifestyle changes, which includes physical therapy, can include occupational therapy, psych rehab, and self-management techniques. and can also include some repurposed drugs, which we have talked about in previous sessions and will talk, in our subsequent sessions as well. So this is what we are talking today is a really powerful sort of strategy to help these patients. That's one comment I want to make. And the second comment, I really want to emphasize that, Lindsey, you talked about, breathing techniques and activating the parasympathetic nervous system. And in fact, there have been many studies which have shown the impact of these, deep breathing techniques on pain, chronic pain relief as well. A lot of our patients are dealing with chronic fatigue and arthralgias and myalgias, and this breathing can be helpful in that as well. In fact, there is a wonderful program developed by Stanford which is called Empowered Relief, which is focused entirely on breathing techniques, the use of breathing techniques like a 12-minute breathing program, which is helpful in patients with chronic pain. So I just want to, emphasize the importance of this and just the physiology behind it, which helps us understand why it works. So over to Nick for the next question.
Great. So this is another question where we'd love to hear from both of you, but what's something that you feel that every clinician or kind of member of the community at large should understand about the lived psychological experiences of long COVID that you've seen in your practices?
Yeah, I think the thing that comes up for me is that long COVID symptoms and the severity can greatly vary from patient to patient or person to person. And so the line that I like to use or pass along is that, when you've seen one patient with long COVID, you've seen one patient with long COVID. And so that's, I think, my short and sweet takeaway from what I've seen.
That is very well said. Very well said, Tracy.
Thanks.
Go ahead, Lindsey.
Oh, I just think that's a great way to approach it, with that humility of like our patients are people who are experts on themselves and their own experience and their symptoms. And so I think approaching with that kind of humility that you just said, Tracy, is exactly what I would recommend as well, and really is the foundation of that trauma-informed care, where we are seeking to create a relationship of transparency and safety, to kind of create that kind of treatment team.
I think that, there are so many different phenotypes, so many different clusters of symptoms that no two patients that are presenting to you will be alike. However, as clinicians, when we see these patients, just, there are some patterns of their presentation. In addition, there is sort of this history of acute COVID infection, followed by this pattern of lingering symptoms that just should trigger, the possibility of long COVID. There are no biomarkers yet that have been developed for long COVID, and we are, in a way, it is a diagnosis of exclusion. However, the disease, sort of it can be continuous or relapsing, remitting, or it can have a pattern which it does not have to start right away after acute COVID symptoms. So I think just the sort of unknown of about long COVID is just confusing. However, what our endeavor here with these webinars is to just stimulate that thought and to see pattern recognition in these patients. And I hope that our listeners today, gained a lot of information from your program, Tracy and Lindsey. And are there any resources that you can share with us, that we can share with our listeners today, and that they can use? I know that you mentioned that there were some resources on diaphragmatic breathing.
Yes, what would be the best way to share those?
If you, yeah. Go ahead, Nick.
So I can follow up and we can send an email out to the group with all of those resources together and include it in the link to the or in the recording, the video recording on YouTube. We can put links in.
Great, thank you.
That will be awesome. And I know that we would love to hear from you again, Lindsey and Tracy. I know you are wrapping up your research as well. It would be great if you can come back and talk about sleep disturbances. I know that you have published recently on sleep disturbances in long COVID as well. So I think we would love to invite you back and talk about that also. And I would love to hear more about your group sessions and the results from your research. Thank you for your time today, Lindsey and Tracy. Thank you for coming. And we really appreciate you and your work. And we could not, sort of see this program, the long COVID program and the clinic running successfully without you. Thank you very, very much.
Thank you.
Thank you, everyone, for joining today's session. And Nick, please tell them about the recording.
Yeah, so I'll send up a follow-up email, including those resources. And again, all of our recordings can be found on our YouTube channel, and we will also send out a link to that YouTube channel. And we will see you all next time.
Thank you. Bye.